There is no bias. Yes. Yes. Good morning, all. Just a few seconds left for 12. And wishing you happy Independence Day. We are here to have a unique program where our own students are going to teach us. So we are looking forward to various wonderful presentations from all the new Generation Z, I should say, or millennials, whatever. And they have been given topics beforehand. They will be judged by three eminent judges, Dr. Malik Ma'am, ex-president MOS, Dr. Purvasha Narang, who is from AIMS Nagpur, and we have Dr. Rupali Nerlikal from Pune. So they will be judging you on various aspects. So 4 marks for the presentation, 4 marks for communication skill, 1 mark for sticking to time, and 1 mark for questions. Right? So here we go. Team 1. We will start with Prerna. Are you ready? Prerna Vilas. Is she there? Yeah, Prerna Mishra. I think she's connecting.
Yes, ma'am.
Yes. You can start your screen. Share the screen. And Arvind, you make a note of the timings. Can you expand it a little, Prerna? It is in vertical.
Yes, ma'am.
Squeaking noise seen.
Naina, ask everybody else to mute other than the present.
Yes, yes. Please, a kind request to all who have logged in to unmute. Sorry, unmute only Prerna. Rest stay muted. Thank you.
Yes, ma'am. Can you hear me, ma'am?
Yes, Arvind, look at the tab, please.
Yes, ma'am.
Yes.
No.
Yes, ma'am.
Yes, Prerna, speak on ophthalmic viscosurgical device.
Okay, ma'am.
Your
Good afternoon, everyone. Myself, Dr. Prerna Mishra, going to present on ophthalmic viscosurgical devices. So these are my learning objective in this learning program. OVDs are the transparent gel-like substances with a dual property having fluid viscosity and elasticity of gel and solid. The rheological properties are viscoelasticity, viscosity, coatability, and pseudoplasticity. Viscoelasticity is the tendency to resist the deformation and to regain its original shape. Then viscosity is the resistance to flow, and it is inversely proportional to the temperature and directly proportional to the molecular weight and concentration. One second. The pseudo coatabilities, ma'am, 1 second. There's
Go back, don't get nervous.
any issue, Prerna?
Yes, ma'am. The second property is viscoelasticity. Viscoelasticity is tendency to resist the deformation when the external force has been removed. Viscosity, the resistance to the flow, it is directly proportional to the molecular weight and concentration and inversely proportional to the temperature. Then pseudoplasticity is to transform under pressure, and the more pseudoplastic a material, the more rapidly it changes, being raised to the thin and watery, and it is directly proportional to the higher shear stress. Coatability is defined by the two factors, that is surface tension and contact angle. More the contact angle and more the surface tension and contact angle, more will be the less will be the coatability, and lower the surface tension and contact angle, less will be the coatability. The classification of OBDs are like high viscous cohesive devices, low viscous dispersive devices, and viscoadaptive devices. This is the full spectrum of OBD. Cohesive devices have high viscous substances having high molecular weight and long chain adhere to themselves and high plasticity and easy to remove from the eye. Some examples are super viscous, they are Hilon GV, and viscous, that is Anvis and Ibis, and Hilon 1%. Dispersive OBDs are low viscous substances, low molecular weight substances, they adhere well to the external surface, low degree of pseudoplasticity is there, more difficult to remove from the eye. Medium viscous are viscose and very low viscous are occupore. Cohesive devices we use to deepen the anterior chamber to enlarge the small pupil to dissect the adhesion and during the IOL implantation. There are some advantages. They maintain the space at the lower shear stage, and if retained, there is lower risk of post-operative IOP. So there are some disadvantages also. Minimal coating, also less endothelial protection is there. And the dispersive devices advantages are their excellent coating and super endothelial protection. And disadvantages are they do not maintain the stain and high risk of post-operative IOP rise. There are visco adaptive devices also. They contain both the properties like visco cohesive agents at lower flow rate and pseudo dispersive agent at higher flow rate. This is Hilon 5. Clinical uses of OPD, there is cataract surgery, corneal surgery, pancreatic keratoplasty, glaucoma surgeries, and ocular trauma. So viscoelastic use for capsular access, capsular forming.
Prerna, your time is over.
Yes, ma'am. So
Okay,
there is
Prerna,
launch is to protect the corneal system.
we'll have to stop. Your time is over. We'll have to stop.
Yes, ma'am.
Naina, do we allow her to continue or what should we do? Naina?
Madam, you can ask questions now.
How many? Yeah, how many? Because
One
how
question
many
per
books?
judge,
Yes, yes.
max. Yeah.
Which is the OVD that you prefer if you were doing a phaco? Prerna.
Ma'am, we prefer Hilon, which is a dispersive devices because it is because it retain and it maintain the it coats the endothelium and protect the cornea, and then it will ma'am. So, ma'am, it's a cohesive device, and we prefer Hilon in phacoemulsification because it adhere and it's having a intermolecular bond and it's having high viscosity. So, and it's easy to remove also.
Okay,
So
thank
we
you.
prefer Hilon 5, which is a cohesive device.
Which viscoelastic would you prefer if the patient is known to have a lot of guttata and is undergoing surgery for a dense cataract?
Ma'am, we use dispersive devices because we use viscolon and or viscocoat because it coats the endothelium far better than the cohesive device.
And as far as the dense cataract goes, would you prefer any type of surgery?
For dense cataract, we use small incision cataract surgery we do, and we prefer the dispersive devices. Dispersive
Thank
device
you.
like.
Thank you.
Thank you, ma'am.
Purvasha, any question?
Ma'am, I think I'll take the next.
Okay, perfect.
Yes,
So,
for paucity of time.
thanks a lot. Naina, you can ask the next person.
Yeah, next one is Baswa Kiran. Are you there? Please start sharing. Dr. Baswa Kiran, I can see you.
She has to stop sharing first.
Yeah.
Yes, ma'am.
Prerna.
Yes.
Stop sharing your screen.
The previous presenter has to
Yes,
stop
yes.
sharing.
अब आपका बस
Give space to Baswa Kiran.
sharing stop कर दो.
Stop sharing is at the top end, red thing. You can click on that. Yeah. Okay.
Yeah.
Now,
No.
Kiran.
Yes.
Good morning, everyone. This is Dr. Basarkan Patil from Somaya Hospital to present a topic on congenital ptosis. My learning objectives are definition of congenital ptosis, demographics, pathophysiology, associated syndromes, diagnosis and management. Definition: congenital ptosis is abnormal drooping of upper eyelids since birth or occurs within first year of life. Demographics: according to the recent study, over 40-year time period of incidence and demographics of childhood ptosis published by Grandpentog et al., nearly 90% of known cases were of congenital onset. The incidence was 1 out of 842 births, 3% were bilateral and 68% were left-sided. The pathophysiology: congenital ptosis can be associated with the anomalies of extraocular muscle development, levator muscle, and aponeuritic tissue replaced by the fibrous and adipose tissue, and there can be a complete replacement of striated muscle. In nerve innervation, neurologic dysfunction or neuromuscular junction failure of the levator. Then the associated syndromes are blepharophimosis, characterized by blepharophimosis, epicanthus inversus, helicanthus ptosis. Then we have a 12-year boy presented with the ptosis of left eye. Since 10 years, there was history of forceps delivery. The boy suffering from the congenital Horner syndrome. This is defect in the sympathetic innervation characterized by the triad, ptosis, meiosis, and anhydrosis. Also, the heterochromidia iridis was present. Then we have Marcus jaw winking syndrome, in which the retraction of the ptotic eyelid with jaw movement due to stimulation of the ipsilateral pterygoid muscle. Duane syndrome, the sixth cranial nerve fails to innervate the lateral rectus muscle. Instead, the third cranial nerve innervates it. Then we have congenital fibrosis of the extraocular muscle. Congenital non-progressive ophthalmoplegia is present. Then we have periorbital tumors, neuroblastoma, leukemia, lymphoma, and the picture showing capillary hemangioma responsible for congenital ptosis. Then the diagnosis: detailed history includes birth trauma, onset, family and medical history. Physical examination consists of the visual acuity, refractive error, cycloplegic refraction, fundus examination, head tilt, ptosis evaluation, consisting of the marginal reflex distance 1, marginal reflex distance 2, margin crease distance, vertical fissure height, levator action, frontalis overaction, extraocular muscle movements. Then we have lag ophthalmos, Bell's phenomenon, Marcus jaw winking phenomenon, and late line. Management: early consultation to avoid amblyopia, observation in mild congenital ptosis. Surgery is preferred at the age of 3 to 4 years. Immediate surgery is indicated in case of amblyopia, astigmatism, head tilt, severe ptosis. The surgeries are fascicular servant, tarsofrontal sling surgery when the LPS action is less than 4 mm. Then levator resection is the most common surgery when the is done when the LPS action is more than 4 mm. The fascicular servant procedure showing full thickness tarsal incision followed by excision of the tarsoconjunctival molar complex with monopolar cautery, then conjunctival sutures. Then we have tarsofrontal sling surgery using 800 micron silicone. One question to you, like what materials can be used for the frontalis suspension? The answer to the question is like fascia lata, nylon suture, palmaris longus, etc. Then we have the skin incisions are marked, skin incision taken. Then we the creation of the prefrontalis pocket, followed by the creation of the tarsofrontal sling. Both ends of the silicone pass through the silicone sleeve, placing of the reverse flow suture. Then we have levator resection performed when the levator function is more than 4 mm. There is marking of the skin incision, fractional sutures taken with 40 silk, skin
Your
incision
time
with
is up,
monopolar cautery,
madam. Your time.
suborbicularis dissection, injection of the xylocaine, then
So
fractional
this is the-
sutures,
Hello. Over.
levator dissection of the conjunctiva, dissection of orbital
Yes,
septum,
madam.
and division of the middle and lateral horns of the
So
pelvis,
please stop.
followed by the excision of the levator, orbicularis closure, and skin closure.
Dr.
This is a summary
Basva
of my
Kiran.
topic.
Okay, done. हाँ.
Okay, fine. ठीक है. Okay. Anybody would like to go first?
Thank you so much, Basavakiran, for this extremely comprehensive coverage, and you've shown the steps of surgery. You've taken a quiz also. And that shows you are getting towards being the teacher of tomorrow. Very good. I would like to ask you if how do you decide in a child when to operate if the patient has ptosis? What are the factors that you will consider?
Ma'am, firstly, we'll look for the main is the levator action we'll look for. And in case of ma'am, if it is severe, if there is we will look for amblyopia, whether it is severe, then whether it is severe or complete ptosis, we'll go for like early surgery in case of head tilt also.
Okay.
I think I'll pass on this one. Rupali, anything you want to ask?
In the interest of time, we'll pass.
Yeah. Will
Let's
you
each
stop
take one
sharing?
question.
I think let's stick to one question each. So, okay.
It's easy to give marks also. Otherwise, we'll have to give in decibels.
No, not giving, not doing that.
Stop sharing, Dr. Baswa Kiran. We
Stop.
have the next speaker waiting. Dr. Apurva Ranjalkar, are you ready? Yes, Dr. Apurva?
Yes, ma'am.
Yeah, come on. Share your screen, please. Any difficulty?
Ma'am, I'm unable to share my presentation actually.
Ready? Wait, try again. Let it try it, Naina.
Or we can take the next teammate, Dr. Aryamurthy.
Ma'am, I'm getting it.
Okay,
That's good.
go ahead. Okay.
Yeah, make it full screen.
Yes, ma'am. Is it being seen, ma'am?
It's not full screen yet.
It's visible, but make it full screen mode.
Go to slideshow and
Yeah,
click
down, down.
down also or up. Yes. Oh, yeah.
Right hand bottom, there is a sign there you can click. So it will go to the slideshow. Right side bottom.
Yeah, click. Gone.
Next to it, yes. Correct.
Good afternoon. My name is Dr. Apurva Ranjalkar, and my topic for today's presentation is contraindications for laser refractive surgeries.
Second, it is not full
First,
screen.
let us understand what is a refractive surgery.
Purva, not full screen yet. Make it full screen.
Yeah, it didn't get clicked, I think. You
Yeah.
were, your pointer was there.
You didn't click it. Click
Down.
on Purva. If you just go above also on the slideshow and click on it,
One more, yeah.
you come.
Where
That-
you have the save thing, upper left is also one option. Or simple, the previous one which you clicked, which was lower down near zoom. You have 71% zoom, uske बाजू में है.
Yes, ma'am.
Arey nahi, you've gone out.
You have exited, beta.
You stop sharing. Share again. And now do one thing. Go to your show.
Next to it. No, the other icon.
No,
Don't fit it. Yes. No. अभी उसके बाजू में थे ना screen project. Yeah. Click on that.
on it. Go and click on it. You're not clicking. You're just going on it.
Ma'am, I clicked on it actually.
No, it
Okay. Then go to the left upper corner. There is from beginning है. Go up. उसके ऊपर. Left बेटा. पूर्वा. Left ला इथे वरती from beginning आहे बघ फाईलच्या खाली. Left up.
Apurva, you should be knowing how to do this.
Left up.
Here. Just below file. She's telling you. Just below file from beginning. Start.
Madam, it's okay. This is zoomed enough. We can go.
चलो ठीक है
It's okay for you. Yes, ma'am.
जाने दो, let's not waste time.
Hmm.
Ma'am, should I start again?
Yes, please. Yes.
Hmm.
Okay, timer. Start the timer.
Okay, go ahead.
Yes, great. Chalo.
Good afternoon. I am Dr. Apurva Ranjalkar, and my topic for Teachers of Tomorrow presentation is contraindications for laser refractive surgeries. So first, coming to what is a refractive surgery, it is basically a range of procedures which are aimed at changing the refractive errors of the eye by altering the cornea or the lens, which are the two basic refractive structures of the eye. And the aim is to attain a proper, clear image on the retina. It is used for the correction of myopia, hypermetropia, and astigmatism. But correction of presbyopia is yet to be achieved on a satisfactory basis. Uh, Coming to the classification of refractive procedures, in short, first is the keratorefractive procedures, which are basically aimed at altering the corneal curvature. In that, we have incisional refractive techniques, in which first is radial keratotomy, astigmatic keratotomy or limbal relaxing incisions, hexagonal keratotomy, and opposite clear corneal incisions. Then there is the lamellar corneal refractive procedures, which have freeze keratomiliosis.
Purva, your slides are not moving here on screen. Are you moving them?
Yes,
Wait,
ma'am.
next. Yeah, we are stuck at the title page. Yes.
Now is it okay? Is it being seen now?
Yes, but you'll have to manually do it. You have to go on clicking on the next.
Yes, ma'am. I am clicking on the next slide.
Okay, go ahead, please. Go ahead.
Go ahead. Go ahead. Apurva, go ahead.
Yes, ma'am.
Wasting your time.
Then there is the refractive lenticule extraction, that is RELEX, and small incision lenticule extraction, that is SMILE. Then there is the laser ablation corneal procedures, which include photorefractive keratectomy, laser subepithelial keratomiliosis, and LASIK, that is laser in situ keratomiliosis, which is the most commonly performed procedure. This is an image showing the difference between the photorefractive keratectomy and laser in situ keratomiliosis. Uh, Moving on, we have the corneal shrinkage refractive procedures that include thermal laser keratoplasty and conductive keratoplasty. And the final one is corneal implants, which have intracorneal contact lenses and intrastromal corneal ring implants, that is INTACs. In lens-based procedures, there are only two. First is phakic refractive lenses, in which an additional lens is inserted, which is an implantable Collamer lens, and refractive lens exchange. In combined lens and corneal refractive procedures, there is the bioptics and trioptics, in which is used in a very high grade of myopia, in which a lens phakic procedure is done first, followed by additional myopia is corrected with the help of a LASIK or a corneal procedure. Moving on to the contraindications. First, I would like to address the systemic contraindications.
Slide. Change your slide. You're still stuck on that slide. You haven't gone to the next slide. Yes.
The systemic contraindications, first and foremost, is a patient less than 18 years of age. Then second is unstable refraction. So these two are basically because once the refractive surgery is done, we cannot keep on repeating the procedure. So we will perform the surgery only once the refraction has been stabilized. That occurs normally by 18 years of age. Next contraindication is diabetes mellitus with reduced corneal sensations and thyroid orbitopathy. So these 2 points are addressed because of dryness of eyes is a big complication after refractive surgery that accounts for around 10 to 20% of the complications. So these two will lead to increased dryness. So in these two conditions, refractive surgeries are contraindicated. The next contraindication is autoimmune or connective tissue disorders like rheumatoid arthritis, systemic lupus erythematosus, PAN, Marfan syndrome, Ehlers-Danlos syndrome, Keloid, etc., and immunodeficiency disorders. These are a contraindication because these will lead to abnormal wound healing and leading to post-operative haze. Basically, in flap-based procedures like the LASIK, these will not
allow the flap to be healed properly. So this can lead to postoperative haze and failure of the surgery. Then systemic infections like HIV, HCV, HBV, and tuberculosis are again contraindications.
Purva, stop. Your time is over.
Yes, ma'am.
Okay, now suppose a patient comes to you whose power is -8 and -10. What procedure will you advise her? She is past 40, she's almost 45. She's already using contact lenses since a long time.
Okay.
What would be your advice?
Ma'am, first of all, I will ask her to stop the wearing the contact lenses for at least 2 to 3 weeks because contact lens usage can alter the curvature of the cornea.
No,
And
but 1 minute. Are you planning? What are you planning? Why are you asking her to stop wearing contact lenses? What plan do you have in mind?
ma'am, because the patient is a high myope, I would like to go for a combined lens plus cornea based procedure.
Rather heroic procedure. You sh- what ad- what will you tell the patient? How will you advise the patient about this procedure? You don't want any medical legal complications afterwards, mind you.
Ma'am, I'll explain to the patient that because she's in her 40s, there is also this is an age for presbyopia as well. So, so I'll advise the patient that we will not have a proper success rate because the refractive surgeries are not yet successful for presbyopic patients. These are basically
So that means you want her to continue with her contact lenses and wear presbyopic glasses to put
yes.
it, isn't it? Then why ask her to stop wearing contact lenses? Okay, next. Anybody?
Purva, can you stop sharing the screen meanwhile?
Yes.
Thank you.
Purvasha, Rupali, any question?
Aryamol, are you ready? Any more questions from the judges?
No, ma'am.
Just
Thank
that
Uh,
she did mention a number of types of procedures. So would some other procedures, the patient is hell-bent on getting a procedure, would something else in that inventory you mentioned in your initial few slides be more suitable to this patient at that point in time? 40 plus presbyopic.
Yes, she's asking about my patient. What would you advise for her? Other than what we already discussed.
Ma'am, we can go for a refractive lens exchange.
Correct. So that would be a better option. If
Yes,
the
ma'am.
patient has come to you for refractive surgery, so obviously she's not keen on wearing lenses or progressive glasses,
Yes, ma'am.
right?
And
So
this
that
is
is
an age in which she can develop cataract also. So if we
correct. So that
go
is
for a phakic refractive lens, it will increase the risk of cataract and lead to an earlier development of cataract. So might as well we go for a refractive
correct.
lens exchange.
Fine. Fair enough.
Okay, you can stop sharing your screen, please.
Yes. Next is Dr. Aryamol. Are you ready? Team 2,
Yes, team 2,
participant 2.
yes. Optic disc examination in glaucoma. Are you ready with your presentation, Dr. Aramoy?
Yeah, I think she is doing that.
She's there.
Aravind, can you get all the PPTs together on your email ID and then project?
Yeah, because I think some of them, but I don't know. I think
But they should be knowing. They
They
should
should
be knowing it.
Purosha, by now, I think they should be knowing how to slide share
Yes, ma'am.
and a slideshow, how it goes.
Yes, Aryamol, can you make it full screen, please?
It's gone off.
Okay. We are wasting time here.
It's okay. Make it full screen, Aramoy.
Yes. So there is that slideshow scene.
I think he's on an Apple device.
Yes, Apple. Yes, yes. Great. Yes,
Okay.
Aryamol, it's visible well.
Go ahead.
Please start. Timer Timer, please. Arvind, yes. Unmute yourself.
Arya, unmute yourself and start. Your time is started.
We are not able to hear you. Dr. Arya Moy.
Please reset the timer.
Yeah.
No,
You are okay with the slideshow, beta, but
Yes.
we couldn't hear you.
check your volume.
Yes, you are there, but can you speak?
Hello, Arya. We can't hear you.
Apurva, is she there with you close by? Can you help her? Can you communicate this to her?
Don't do that. Don't go back.
You are fine with the slideshow. You are perfect.
Just check your volume on your laptop. Check the volume on your laptop. It might be 0. Hello, Arya. I think can we go to the next person till uh, he or she checks how to do it?
I can see her mentor here. Dr. Sujit, can you just tell her?
Can you help her out?
Yes, ma'am. Yes, I will just convey the message. 2 minutes, ma'am.
Then shall we go ahead with the team 3? Meanwhile, we'll come back to her if it's okay.
You can
Yes,
come.
ma'am. Yes. Okay. I will just ask her to see the volume.
Yes, please.
Ask
Thank
her to
you.
stop sharing. Check
Please
her.
stop sharing. Please stop
I think she
sharing.
can hear us.
No, it doesn't seem like it, Nana.
Nahi kya? Okay.
No.
She
But-
started sharing as soon as I said.
She needs to check her volume.
Shall we go to the team 3 then?
Yes, I think we are
Yes,
waiting.
ma'am.
It's okay.
Yeah.
She has to stop sharing.
Yeah.
Please tell her to stop sharing. Yeah. Let's
Okay.
take next.
Yeah, we will move on to team 3. First speaker is Dr. Aman Dalal. Are you there? Are you ready, Aman?
Yes, ma'am. Good morning, everyone. I will
Good.
start sharing my screen now.
Yes, please.
Okay, is it visible?
Yes.
Yes.
Go ahead.
Okay.
Yes.
Good morning, everyone. Today I will be teaching on cornea, its anatomy, and the clinical significance. Topics discussed will be the following, including introduction, dimension, and the layers, and the surgical limbus. Cornea is the transparent front part of the eye covering the anterior chamber and plays a role in refraction, contributing to 2/3 of the optical power. Dimensions are anterior surface is elliptical with horizontal diameter more than the vertical. Posterior is a spherical surface of around 11.7 mm diameter. The difference in dimensions leads to difference in the refractive powers of the surfaces. Radii of curvature are anterior surface 7 to 8 mm, posterior 6.5 to 7 mm. Conditions with large radii of curvature present as flattening or cornea plana. Steepness manifests as keratoconus. Less than 11 mm sign can manifest as a microcornea. For newborns, it is less than 9 mm. Megalo is conditions with more than 13 mm horizontal corneal diameter. Layers of the cornea visible on the slit lamp imaging are epithelium, the basement membrane, anterior stroma, posterior stroma, and the endothelium. This represents a histological section of the cornea, as seen stroma occupying 80 to 90% of the size. Epithelium is divided into 3 strata, the superficial being 2 to 3 layers squamous cells, the umbrella and wing cells, followed by the columnar basal cells or the germinative layer. As said in the XYZ theory of corneal maintenance by Thoff, X represent the proliferating limbal basal cells, Y are the centripetal migrating cells, and Z are the desquamating superficial cells. Epithelial dystrophies will manifest as pain and frequent erosions with blurring, like mapped out fingerprint dystrophies or epithelial basal membrane dystrophies. Bowman's layer is the anterior stromal condensation. It is an acellular layer 8 to 14 micrometer thick with randomly oriented collagen fibrils. Bowman layer dystrophies in childhood manifestation are seen as recurrent corneal erosions in the child with honeycomb pattern appearance. Example, Thiel-Behnke Rice-Buckler dystrophy. The stroma is 90% corneal thickness. It is a neural crest derivative, 500 micron thick layer with stromal lamellae produced by the keratocytes and glycosaminoglycans. Here are keratan sulfate, dermatan sulfate, or chondroitin sulfate. The layers of stroma lie parallel to each other and the consecutive layers are at 90 degrees, basically contributing to the corneal transparency. Salzman nodular degeneration is a degenerative condition involving superficial stroma and Bowman's membrane. Predecimates or Duas layer. It is an elastin-rich acellular 10 micron layer with type 1 collagen more than type 6 and scantily spaced coarse fibers. Clinical significance useful for dark surgeries. The type 1 and type 2 bubbles. Type 1 preferred for dark surgery is a air bubble formed between the deeper stroma and predecimate layer. Type 2 being formed between decimate layer and a predecimate layer. Also in acute hydros for compression sutures. Decimate's membrane is a type 4 collagen-rich basement membrane for corneal endothelium visible in this ASOCT, site for copper deposition in Wilson's disease, and thickening of decimate membrane can manifest as outgrowths or excrescences or guttae, as in Fuchs endothelial dystrophy causing edema. Endothelium is the deepest hexagonal monolayer neural crest derivative. It is visualized using either specular microscopy or specular reflection for slit lamp. Endothelial count at birth is 4,000 to 5,000 cells per millimeter square, reduces in adults to 2 to 3,000. Sodium potassium pumps are present here, which are metabolically active for relative dehydration, maintaining corneal transparency. Cell loss is irreversible and compensatory is pleomorphism and polymegatism of surrounding cells. This is specular microscope for the same. Surgical nimbus is the external landmark for incisions in cataract and glaucoma surgeries. It has a blue-gray appearance due to light scattering at corneal scleral interface.
Dr. Aman, your time is up.
Okay. Okay. Thank you so much.
Okay.
Good presentation. It was very well put together. I think I really like that part about it. Why were anterior chamber lenses discouraged? What was the reason?
Ma'am, it can come with complication like endothelial touch or shallowing of the anterior chamber, manifesting as glaucomatous changes.
Why glaucomatous changes? Reason for that?
Ma'am, if it hinders with the flow of aqueous humor, then it can lead to raised intraocular pressure.
How will it hinder the flow of aqueous humor? From where to where?
Ma'am, like from posterior chamber to anterior chamber, the haptics of the anterior chamber lenses can interrupt with the flow of the same.
Okay, I'll let it go for now because we don't have that much time. Rupali, Urvasha, anything?
You have mentioned, Aman, that there is a specular microscopy that you do. So
Yes.
it gives us the structural integrity of the cornea indication, or there is also something with which we can find out the physiology or the functional status of the cornea.
Ma'am, it displays the endothelial properties of the cornea, and it is an aid for ensuring that corneal decompensation does not take place after any intraocular surgeries. And it is basically an indication that the cornea is healthy in terms of its dehydration maintained by the endothelial
How do you
pumps.
judge that the cornea is
Ma'am,
healthy?
Shape of the endothelial cell, the endothelial cell count,
Yes.
and the density of endothelial cells.
Any indirect way of knowing the function of cornea is intact? On the specular itself, one value which will give you whether the corneal endothelium is still working fine. Pardon?
Yes, speak up.
Endothelial cell density,
Mm-hmm.
that can be an aid.
Okay.
I think we'll let it go now.
The
Let's-
next participant is Ganesh Ambekar. Dr.
Yes, ma'am.
Ganesh, are you ready?
Yes, ma'am. Am I
Yes.
audible?
Yes, you
I
are.
am audible but not visible as yet.
Please start his screen share.
Can I start, ma'am?
Yes.
Yeah, go. Go ahead.
Happy Independence Day to all. My name is Dr. Ganesh Ambekar. I
Ganesh,
will be presenting on vitreous substitutes.
Yeah.
As
Open up your,
presentation is not open.
yeah. It is seen unopened. The folder, can you open? You have selected it. Usko double click karo. He is also on Apple, I think. Yes, and make it full screen, please. A technical person, can you guide us? Because the previous participant with Apple also had some difficulties. Yes, Arvind, can you guide them? Ganesh, you are not audible at all.
is it
Yes,
seen, ma'am?
yes. Start
Yes,
the
now
timer.
yes.
Yes, you are audible, visible. Start the timer.
Good afternoon, everyone. As we know that vitreous humor is a transparent gel in the posterior segment of the eye, and it is removed during vitrectomy done for various indications. Since it is not actively regenerated, we have to fill it with another substance called as vitreous substitutes. So the vitreous substitute should mimic vitreous in its form and function, and also it should be manipulable. To classify vitreous substitutes, they are classified as gases, liquids, and uh, polymers. Gases, commonly used gases are SF6 and C3 effect. Commonly used liquids are balanced salt solution, PFCl, and silicone oil. And polymers are new experimental drugs.
Slide. Ganesh, go to your next slide.
Can we advance the slides?
I don't think we can.
Ganesh, you are not
Ganesh?
audible. Your slides are not moving. Just look at it.
How were you doing it before this?
Ma'am, just like this, but I don't know how to.
So there is a tiny icon in the top bottom, bottom left.
Yeah.
Yeah, huh.
Oh,
Go back to the slideshow.
go back to slideshow.
There's an icon which is almost transparent.
Yes. Now,
Inferior, the left bottom. Yeah,
Bottom?
there is yeah, this one. No, just next to it. Yeah, good.
yes.
Keep your cursor there and press on that only. Don't move your cursor. Good.
Not able to click on your pad and advance the slide. Keep your cursor on that icon. Your slide is not
Yeah.
advanced.
Yes, now you start.
Now go ahead. Now go
The
ahead.
ideal
Go
Next.
back if you want to.
No,
the vitreous, the liquids are BS, PFCl, and silicone oils we commonly use, and polymers are the new experimental substitutes. Coming to the gases, they are non-toxic, inert, and insoluble in aqueous. They are buoyant, so they does not effectively tamponate the inferior retina. They have high surface tension, so they work as good tamponade on the surface in which they are in contact with. They also expand after injection, so there can be sudden increase in IOP causing CRAO. So we should also avoid air travel. They dissolve spontaneously, so there is no need to remove it. Some commonly used gases are SF6 and C3 effect. SF6 doubles in its volume in 24 to 48 hours, and C3 effect quadruples in its volume in 72 to 96 hours. Coming to the liquids, the BSS is mandatorily used during PPV to prevent the integrity of tissues and cells because its ionic composition, pH, and osmolarity is similar to the aqueous humor. Coming to PFCl, they are fluorinated synthetic carbon-containing compounds having high specific gravity, so they can be used intraoperatively to temporarily flatten the retina in the repair of complex retinal detachments. They have low viscosity, so there is better ease of injection and removal and manipulation. Their refractive index is like that of water, so there is better visualization intraoperatively, but they have high retinal toxicity because of their high specific gravity, which mechanically compresses and disorganizes the retinal structures. Coming to silicone oil, they are polydimethyl siloxanes. They can have different viscosities. 1000 and 5000 centistokes oils are used commonly clinically. Their refractive index is like that of vitreous, so early visual rehabilitation is established. They are ideally removed 3 to 6 months after surgery. Their specific gravity is slightly lower than water. Therefore, tamponade of the inferior retina is difficult. To overcome this, we mix silicone oil with semi-fluoride alkanes to form heavy silicone oils, which have specific gravity of 1.03 to 1.1. So, we can use it to treat large inferior breaks and RDs complicated with inferior PVRs. Coming to polymers, first they used the viscous solution of uncross-linked polymers, but they were having short duration and there was no tamponade. Then we use preformed chemically cross-linked hydrogels, which are having long acting and they were having tamponade. But as it was preformed hydrogel, there was fragmentation of the injection and there was also cross-linker toxicity. Then we chemically cross-linked the hydrogel in situ. So there was no fragmentation upon injection, but there was monomer toxicity. To overcome this, we physically cross-link the hydrogel using pH or temperature in situ. So there was no monomer toxicity. In the future, hydrogel-based vitreous substitutes can be used for both quick
Time
and
is
continuous
over.
release of drug,
Even some more
and
time.
also
Okay.
okay. These
Time
are my
and-
references.
Okay.
Please finish. Good. Good job.
Very good. So, Dr. Ganesh, do you know how do we sterilize vitreous substitutes?
Dr. Ganesh.
Ganesh, and in the meantime, stop sharing a screen
Yeah.
also. Ganesh, madam has asked you a question.
Ganesh,
Are you aware of a method?
are you able to hear us, Ganesh? First, you stop screen sharing.
Yes, ma'am.
Ha. And answer the question asked by Dr. Purvasha, ma'am. Did you
Yes,
hear
ma'am.
the question
can you
or you
repeat?
want it to be repeated?
Can you repeat the question, ma'am?
Yeah, sure. So I just want to know, how do you sterilize vitreous substitutes? Because it's a thing that goes inside the eye. So do we need to, and how do we sterilize it?
We sterilize it using ethylene oxide, ETO sterilization.
Okay, can we go back to Arya Mall before Monish starts so we can finish with team 2?
But
Are you okay? Shall we go ahead with your presentation?
Aryamal,
Dr. Arya Mall, can you hear us?
Yes, ma'am.
have you,
Would you like to share?
Yes, ma'am. I have joined from Apurva Renchekals.
No issues, no issues.
it doesn't matter. Go ahead.
Monish, can you hold on for some time?
Yes, ma'am.
Dr. Arya Mall.
Yes, ma'am.
Monish, stop your screen sharing.
Yes,
Aryamal, yes.
yes.
Make it full now.
Make it full screen, please.
Yes, ma'am.
You're audible also.
Can you go to slideshow, Aramol?
Yes, ma'am. Yes, ma'am.
Go to slide here on top, click on it. Click on it. It's not working.
Can you click on that icon there?
You did, but you did click on it, but it didn't work.
Now, it didn't work even for Apurva.
Go to slideshow. That is the easiest way. Go to slideshow and start from the beginning. From beginning, that is the best way.
Yes, yes.
So, file, home, insert, on top, on top.
उसके ऊपर टॉप अप
Yes, ma'am.
insert के ऊपर है. हाँ हाँ हाँ
Really?
हाँ. Try that. Yes.
Try that.
Click, double click.
It's not working, Naina.
You need to enable
it's getting
editing.
selected,
Enable the
but not-
editing.
You need
One sec. She needs to enable the editing. Just enable
Yes,
that
yes.
editing, that yellow bar. First,
This is
enable that.
protected
It will
view.
allow you to move.
Aryamol, you are in the protected view. That go just follow that, and there is a rectangle white. Yes. Yeah.
enable.
Just click that.
No, now you've gone out of.
No, ma'am. It's not.
No, it'll come.
Don't worry. Go back, share your screen. And then otherwise, shall we take Monish till she
What happened?
learns how to do this?
Share screen. Window.
You know, one small,
Participants, please look into this.
but small hint I would like to give everybody. All teachers.
Especially those who are using Apple format.
No, then even I am on Apple device. But
ये दोनों का गणेश का भी एप्पल का था. Initially there were a lot of glitches.
familiar with your own device, huh? You have to be if you are going to be presenting from it. And it is better to keep your talk on your desktop instead of going into documents and trying to find it there.
Yes.
Keep your talk on the desktop.
Okay, then Aryamol, can you make it more zoom in? जो भी है ना, just like the way Apurva presented,
Yes, ma'am.
and then keep on clicking the slides manually.
First, share your screen.
Yes, ma'am.
I think you are not familiar with her laptop. That's why the problem is coming.
Do you have a video, something, animations in your presentation?
No, ma'am.
Then you can just go and we'll see it in that view only.
Yes, now, see, now go from beginning. Below slideshow on the extreme left is from beginning. Click on that.
Left, उसके नीचे.
Click on that. Double click on that.
Yes, ma'am, I have done.
No, you haven't.
Down.
Down. Not on that one. We're not asking you to click on that.
उसके ऊपर, उसके left.
Okay, current slide से भी चले. ठीक है, करो उसको double click. Double click on that from beginning.
Ma'am, I have done, ma'am. Ma'am, is my slide
Problem
visible?
with the mouse, I think.
Anna, let her present like this.
Yes,
Doesn't.
ma'am.
You can
Yes, ma'am.
go and check.
Please go ahead.
Aryamol, don't get stressed. Can you zoom this? You are 71% zoom. Can you zoom more?
Yes,
So
ma'am.
that we don't get distracted by the left side.
Below.
थोड़ा सा बड़ा कर देगी स्लाइड. बस इतना नहीं. You are going out of screen.
Going out of the screen.
That's bus. I think go ahead. That's it. That's good.
Ma'am, she can come out of the, sorry, I'm interfering. She can come out of the, this is Trupti over here. She can completely come out of it and go on the home slide. There is no need to go on the slideshow. Then it will start playing. All your things will start playing. Otherwise, there is a slide on the extreme right hand side. There are 4 icons, out of which one is popping like a glass. Click on that. Yeah, that glass 3. हाँ, उसके आगे का 1 2 3 4 चौथा हाँ, उसके बाजू का.
Yeah.
Extreme, हाँ. Click on that.
Yeah, ma'am,
Click on that.
She already tried that, Trupti.
Yeah, that was the first thing she did.
She already tried.
Okay.
But it's not happening.
Okay, then it's okay.
I think we should
I have
start
5
the
buttons.
timer.
So we can
Yes,
start the
F5
timer
button.
and we can
Apurva,
start.
allow her to start now.
Yeah, start. Arya.
Timer on, please, Arvind.
Okay, go ahead, Arya.
Good afternoon, everyone, and I'm really sorry for the technical error that has happened. Today, my topic of presentation is optic disc examination in glaucoma.
And in brief, we are going to discuss why we are evaluating optic disc, how and what to look for. So why? We have to identify for the diagnosis, quantifying the amount of damage and monitoring the change, and to assess the progression. But how to evaluate? The slit lamp biomicroscopy is considered to be the ideal method of evaluating optic disc examination, which gives a stereoscopic view. We can examine either using a plus 90D diopter lens or a plus 78D diopter lens. When measuring the size of the optic disc, we should be sure that the correction factor for plus 90D diopter around 1.5 to be added. Direct ophthalmoscopy. Direct ophthalmoscopy gives us a 2D image of the disc, and also the 5-degree aperture correlates with the size of the optic disc. Other modalities are indirect ophthalmoscopy and optic disc photography, which helps us in documentation. So the steps in clinical examination of optic nerve head, which we are going to discuss. The first is the disc size. Always the disc size margin of the disc should be compared with the Elschnick scleral ring and assess the size based on the vertical diameter. Average being 1.5 to 2.2 mm, and always we have to compare with the fellow eye. So here we can see a large disc with a large cup and a small disc with a small cup. So always a large cup need not be pathological. It can be physiological also. And compare the disc asymmetry. So we have to always compare with the fellow eye, where a disc cup disc asymmetry of more than 0.2 may be suggestive of glaucoma. Normal disc is vertically oval and normal cup is horizontally oval. So a vertical oval cup can be suggestive of glaucoma with a CDR of 0.7 as shown in the image is highly suggestive of glaucoma. When examining neuroretinal rim, we have to look for the contour changes, pattern of loss of the neuroretinal rim tissue. Normally, the color is pink because of the presence of capillary, and always the presence of pallor suggests non-glaucomatous changes. See, we have the ISND rule, which is applicable to the neuroretinal rim coined by Eliot Werner. So here the inferior retinal rim is more broader than the superior, then comes the nasal and the temporal. But always remember that this is applicable only for a vertically oval cup. In the image, we can see violation of the ISND rule, which is seen in glaucoma because of the vertical elongation of the cup and progressive loss of tissue from superior and inferior pole. But why the poles? Because the connective tissue is already less in the poles with large pores. And in advanced glaucoma, we can get a lamina dot sign, which is suggestive of deepening of the cup results in exposure of the lamina cribrosa. As shown in the image, we can get a bean pot cupping. Bean pot cupping matlab we have the total loss of the neuroretinal rim with bending of all the vessels at the margin of the disc. And pallor is more suggestive of a non-glaucomatous changes, and cupping is more suggestive of a glaucomatous optic neuropathy. A retinal nerve fiber layer always to be examined in red-free filter, and we might get a slit defect, wedge defect, diffuse defect, and maybe a combination of all. And is seen in 20% of glaucomatous changes. Disc hemorrhage. As seen in the image, we can see a flame-shaped hemorrhage. Is seen in 1.9 to 16.9% of patients with glaucoma, and is also known as trans hemorrhages, but it's not conclusive of glaucoma. So we have the other disc stages, the nasalization of the vessel, arteriolar attenuation. So in the image, we can see bearing of the circumlinear vessel and binating sign. The bending of the vessel is evident with because of the overhanging edges of the cup. When coming to the peripapillary area, we have the alpha zone and beta zone. Focus to be on the beta zone. Localized enlargement of the beta zone may be suggestive of progression of glaucoma. In case of progression of glaucoma, we should be always compare with the baseline documentation and our findings should be focused on the optic nerve head, progressive NRR loss, increased CDR, new RNFL defects. So to summarize,
Time is up.
Sundaresh described 5 hours glaucomatous optic neuropathy. These are the scleral rim. Identify the size of the rim. Examine the RNFL. Examine the region of the peripapillary atrophy. Look for retinal and optic disc hemorrhages. We have discussed already. Thank you.
Stop sharing your screen.
Yes, ma'am.
Rupali?
Yeah.
Any
So you said that the isn't rule is one of the things which we use in glaucoma. Is there an exception to this isn't rule in some circumstances? And similarly, pallor more than loss of neuroretinal rim is more neurologic. Is there an exception to that? Is there some cases where, in spite of this, the patient has glaucoma? You want me to repeat the questions?
Yes, ma'am.
Okay. First is isn't rule. Where
ma'am.
is the isn't rule not normally seen?
Ma'am, in non-glaucomat, it is seen
So
in more
isn't rule is
non-glaucomatous optic neuropathy due to AIO and myopia.
okay? So isn't rule is essentially where the rim is thickest. Okay,
Yes, ma'am.
and it is normally applicable to a normal disc. So a large disc or a small disc, they don't always follow the isn't rule.
Ma'am, only a vertically oval disc will be having will follow the Essen rule.
Okay, and when there is pallor more than rim loss, in which circumstances can it still be glaucomatous?
Ma'am, congenital conditions. So,
I think
No,
let it.
yeah, let it go. Fine. It's acute congestive glaucoma when there is more ischemia, and so they get more pallor than rim loss.
Right.
Who's
So
going
3 teams
to
done.
Monish? Monish?
Yeah. 3 teams done, ma'am. 4th team will start with Monish Nayak. Please, Monish. Yeah, thank you. Aryamol. Yes. Timer, please. Arvind, timer, please now. Yes.
Hello.
Yes.
Am I audible and visible?
Yes, we can hear you.
Hello.
And we
Good
can see.
afternoon, everybody. Good afternoon, everybody. I am Dr. Mohnish Nayak from Grant Government Medical College and Sir JJ Group of Hospital, here to present you my topic, dyes in ophthalmology. What are dyes? Dyes are the compound which can impart color to a substrate when applied. So why do we need dyes in ophthalmology? To appreciate some ocular structure which are not appreciated with naked eye, and to enhance the anatomy of some structure. Some of the common dyes we use in ophthalmology are fluorescein, rose bengal, indocyanine green, lesamin green, tryphan blue, and methyl blue. Coming to the sodium fluorescein, it's a yellow water-soluble dye-basic dye which absorbs blue light and emits yellow-green light. This is the property of a fluorescence, which absorbs a low wavelength light and emits a higher wavelength light. Available in sterile strips, vials, and solutions. Uses of sodium fluorescent dye. Corneal epithelial defect, corneal ulcers, we can use in Goldman applanation tonometry, Siddle's test, Jones dye test, fundus fluorescein angiography, tear film breakup time, and contact lens fitting. Now coming to rose bengal dye. It's a water-soluble brownish red powder available in strips and topical solutions. It can cross the cell membrane of dead and degenerated cells. It has an antiviral activity. It can stain mucous threads and corneal filament. It can also suggest the deficiency of tear film component like mucin and albumin. So it is used in most of the dry eye diagnosis of most of the dry eye diseases and for corneal staining. Now coming to indocyanine green. It is the sterile water-soluble tricarbocyanine dye, absorbs 790 to 800 nanometer and emits 770 to 880 nanometer. Available in vials, it is used for indocyanine green angiography to diagnose CNVM, wet ARMD, and posterior uveitis. It has a high affinity for type 4 collagen and laminin. That's why it's used in VR procedure to stain the internal limiting membrane. Now coming to the lesamin green. It has a high affinity for dead and degenerated tissue. It has a peak absorption at the red end of the visible spectrum at 630 nanometer and stained area is black. Preferred for staining bulbar conjunctiva, and it is used to diagnose dry eye diseases and lead viper epitheliopathy. Available in liquid forms and 1.5 milligram impregnated strips. Now coming to tryphan blue, it is the most common dye used in the ophthalmological OTs. For in the cataract surgeries, we use it for anterior capsular staining with a percentage of 0.06%. For posterior segment surgery, we use a concentration of 0.15%. And for enucleation surgery, to stain the Tenon's capsule, we use the same strength as 0.06%. Now coming to the methyl blue, it is used in the oculoplastic surgeries for skin marking and for scleral marking during scleral buckling. Thank you.
Very good. You stuck to your time. In
Yes,
fact,
before time.
finished before time.
Yes, ma'am. questions, please. Yes, judges, questions for Dr. Monish.
You mentioned that the most commonly used is the fluorescein, right?
Yes, ma'am. In OPDs.
In OPDs, right. And
Yes.
then you've also mentioned there's fundus fluorescein angiography. Are there
Yes,
any
ma'am.
precautions before using these dyes?
Yes, ma'am. Some of the patient can present with hypersensitivity reaction. Some of the atopy may be there. So we have to pre-test the dye before using them. Just give a test dose intradermal before using this dye.
And take a proper
Proper consent, informed written consent before. Yes, ma'am.
That's right. So never forget that.
When you are doing fundus fluorescence angiography, I remember earlier that people would keep an anesthetist on standby also.
Yes, yes, ma'am.
So is that important? Why?
Yes, ma'am. If in case of a hypersensitivity reaction, we might be needing intubation or a ICU setting. That's why we need an anesthetist.
Oh, thank you.
Okay.
Well done.
Thank you so much.
Next, Dr. Diksha Pandey here. She there? Start sharing your screen, please.
Your first slide. Go to your first slide.
You are visible.
Maybe
Presentation mode. Yes, yes, it's done.
Very
Yes.
good. Please
Good
start the timer.
Good afternoon. Myself, Dr. Diksha Pandey from Grand Government Medical College and Sir JJ Group of Hospitals, Mumbai. My today's topic is differential diagnosis of limbal mass. The limbus is a transitional zone at the junction of sclera and cornea. Limbus is classified as anatomical limbus and surgical limbus. Uh, uh, the causes of limbal mass can be as follows, like congenital, inflammatory. It can be due to allergic causes, vascular causes, traumatic causes, degenerative, nutritional causes, neoplastic, and some miscellaneous causes. In congenital causes, you can see dermoid. Dermoid is a yellowish-white mass, consists of epithelium, sebaceous gland, hairs, and then nevus. Nevus is a flat or raised, glazed gelatinous, black or brown mass, which shows tendency to grow during pregnancy and puberty. And then dermolipoma. Dermolipoma is a soft yellow and movable mass, which is a subconjunctival mass, and adipose, which consists of adipose tissue and dermis around. In inflammatory causes, we can see episcleritis and scleritis. In allergic causes, we can see flictin. Flictin is a pinkish white nodule surrounded by congestion, which causes photophobia, lacrimation, and blepharospasm. After that, we can see allergic causes. In allergic causes, we can see venereal catarrh. In venereal catarrh, multiple nodules in the upper limbus, which are white and superficial spots, which are associated with white ropey discharge. And then ophthalmia nodosa. Ophthalmia nodosa is a granulomatous inflammation to caterpillar hair. After that, in vascular causes, we can see hemangioma. Hemangioma is a benign red lesion which blanches on pressure and bleeds on trivial trauma. After that, traumatic causes. In traumatic causes, we can see granuloma. Granuloma we can see after surgical wound or at the site of foreign body. In traumatic causes, we can also see implantation cyst and iris prolapse covered by conjunctiva. In degenerative causes, we can see pingicula. Pingicula is a triangular yellow patch on nasal limbus, which is hyaline infiltration with elastic degeneration of subconjunctival tissue. And then cystic pterygium. Cystic pterygium is a triangular sheet of fibrovascular tissue invading cornea, occurs after recurrence. In nutritional causes, we can see Bitot spot. Bitot spots, it can be seen in vitamin A deficiency. In neoplastic causes, we can see papilloma, which is benign polypoid tumor, intraepithelial epithelioma, and squamous cell carcinoma. Squamous cell carcinoma is a flat granular growth invades underlying structure. Primary melanoma. Primary melanoma is a nodular form, may be pigmented or non-pigmented. In miscellaneous causes, we can see intercalary or ciliary staphyloma, which is a bulge in the limbal area, lined by root of the iris due to ectasia of weak scar tissue, following field perforation, injuries, or corneal ulcers. Filtering bleb, which is followed by trabeculectomy, and parasitic cyst, like cysticercosis and retention cyst. Thank you.
Well in time. Thank you. Questions from the judges, please.
I think I'll pass. Urvasha?
Can you tell me what a Delen is?
Yes, ma'am.
Do you know
Delen.
what a Delen is?
What is the Delen?
Why am I asking this question in context with limbal lesions? Do you know what a Delen
No,
is?
ma'am. No, ma'am. Sorry.
And just to point out, please correct your spelling of Flicton.
Yes, ma'am.
Okay. Shall we go to the next speaker?
Yes.
Next participant, ma'am. Yeah, it is Teenal Wankede. Yeah, she's already on the panel. Yes, start, Teenal. Go ahead. We can see you.
Oh, yes, ma'am. Ma'am, am I audible and visible?
Yes. Yes.
Okay.
Very well.
Good afternoon, respected judges, teachers, and my dear colleagues. A very happy Independence Day to all. Myself, Dr. Teenal. Today, I will be talking about refraction in children. So, how it is different from normal refraction? Objective refraction is usually used to determine the refractive status of infants and preverbal children. It should be accurately and meticulously done. Cycloplegic refraction is preferable due to active accommodation in child. So at birth, eyes are hypermetropic and visual acuity is poorly developed. First 2 to 6 months are associated with a rapid visual development. Visual acuity improves slowly after this period and reaches 6 years of age. Then myopic shift in school age occurs. So according to global epidemiological data, refractive errors are pervasive, affecting 12% of children aged 5 to 15 globally. So this uncorrected refractive errors can have an impact on the children's life, as accurate vision is important because it affects the learning, hand-eye coordination, and cognitive development. Uncorrected refractive errors can lead to reduced academic performances, affecting children's potential. Vision issues might lead to the self-esteem problems and hinder participation in sports and social activities. So evaluation of a pediatric patient, establish a friendly relation with the child and parent, detailed history, clinical examination, visual acuity, measurement of deviation, ocular motility, fundoscopy, and clinical refraction should be done. Cycloplegic refraction in children. So the definition is cycloplegia refers to the temporary paralysis of eye ciliary muscle, which controls the eye's ability to focus on near object, that is accommodation. So what is the purpose? The purpose is by inducing cycloplegia, the child's natural focusing mechanism is temporarily suspended, allowing for accurate assessment of the eye's refractive status. So the procedure is first counsel the parent of a patient, then after cycloplegia by appropriate cycloplegic agent, patient is kept in a room with a dim light, setup of a distance fixation target, then retinoscopy performed. So we use atropine, cyclopentolate, and homoatropine as a drug for the cycloplegia. So the child is usually required to wait for 20 to 30 minutes. We then perform the retinoscopy. The retinoscopy involves shining a light into the child's eye and observing the reflection to determine the eye's refractive error. So any other option for refraction than retinoscopy, if the patient is cooperative, then may we go for the autorefraction, as it more accurately detects the astigmatism than retinoscopy. So post cycloplegic subjective manifest refraction can be done in case of a children with a high hypermetropia who do not tolerate the full plus correction, who have significant changes in refractive error over short period of time, in case of an incomplete cycloplegia, and children with irregular red reflex. So when to prescribe? In case of a hypermetropia, usually correction is not given up to +4 diopter in children in absence of squint. Greater hypermetropia, 2 to 30 correction is usually given. In case of a esotropia, full cycloplegic correction can be given even under 2 years of age. In case of a myopia, Below 2 years, -5 diopter or more should be corrected. Between 2 to 4 years, -3 diopter should be corrected. And more than 4 years, any degree of myopia should be corrected. In case of astigmatism, a cylinder of a 1.5 or more should be prescribed, especially with anisometropia after the age of 18 months. In case of anisometropia, after age of 3 years, anisometropia more than 1 diopter should be prescribed. So what is the primary solution is the eyeglasses are common and effective way to correct the refractive errors in children. So depending upon the refractive error, concave lenses for myopia, convex lenses for the hypermetropia, and cylindrical lenses for the astigmatism are prescribed. Choose a frame that are comfortable, durable, well fitted for the children's active lifestyle. So properly prescribed eyeglasses can significantly improve child's visual acuity, quality of light, and aiding in a schoolwork and activities. So in my conclusion, early detection through the comprehensive eye exam is a paramount, and as uncorrected refractive error can hinder a child's learning potential and overall quality of life. By understanding the type of refractive errors, parents and healthcare providers can implement the appropriate corrective measures such as eyeglasses, contact lenses, orthokeratology tailored to each child's needs. Parents' active involvement in the observing signs, seeking timely care, ensuring compliance with the prescribed interventions greatly influence the successful management of refractive error. Thank you.
Got on time. Thank you. Yeah.
Good.
Absolutely.
Yeah.
I would
Right.
like to ask you a question. What is my amblyopia? How would you define it?
Ma'am, amblyopia is nothing but the lazy eye. There's a in a process of development, there might causes some interruption in the visual processing.
Yes, go on.
Yes, ma'am. So
You no, means at what level will you say this is amblyopia or this is not amblyopia? How much? It is included in the definition itself, in the definition of amblyopia.
yes, ma'am. So if the visual acuity in a children, if the visual acuity of one eye is less and other eye is more, if we follow that patient and if it is not 2 to 6 months, ma'am.
How much less than the other eye? And you're talking of uniocular amblyopia. What if both eyes, if there's binocular amblyopia? Then what criteria will you use? Okay, no problem. Okay, I think Nana, we can go to the next.
Yes, ma'am.
Yes, ma'am.
Dr. Jayashree, she's already there.
Very good. You may start.
Yes, please.
Am I audible?
We
Yes.
can hear you. You can start your
Yes,
presentation.
Jayashree. Timer, please.
A very good afternoon. A happy Independence Day. I am Dr. Jayashree Shivsagar from Grand Government Medical College and Surgery Group of Hospitals. My topic for today is newer intraocular lenses, and my mentor is Dr. Shubhita Paul. So, what was the need of newer intraocular lenses? Earlier, intraocular lenses were used to correct aphasia and give the patient best corrected feature metrics. But now, with the advent of newer technology, we need better quality of vision, accommodation, best corrected visual acuity at all possible points of focus, and spectacle independence. So there is a wide spectrum of intraocular lenses to choose from. The first of them is monofocal intraocular lenses. They provide spherical correction, usually only for the distant vision, and they provide excellent image quality. So some modifications in monofocal lenses are monofocal plus lenses, which provide functional intermediate vision along with excellent distant vision. They also come with automated injector system. They have no glistening. There are light adjustable lenses, which are silicon monofocal three-piece lenses. They change in shape and power in response to UV light, so they are made up of photosensitive material. They are particularly useful in patients with difficult preoperative intraocular lens power calculation and in patients with previous laser vision correction. But the problem with them is they have higher order abrasion due to polymerization by sunlight. Next, we come to extended depth of focus with the EDOF intraocular lenses. So they have a single elongated focal point to enhance the depth of vision. They give us good intermediate and distant vision with minimal glare and haze. Multifocal intraocular lenses, they give simultaneously distant as well as near vision. They are of two types, refractive, diffractive, and apodized refractive. But the disadvantage with these lenses are loss of contrast sensitivity, they give glare and halos, and they require neuroadaptation. Modifications in multifocal intraocular lenses. These lenses can be made with UV and blue light filtering material which protect from harmful UV rays of the sunlight. They can be hybrid lenses, which are partly trifocal and partly EDOF, which reduce glare and hazard. Toric lenses are hydrophobic acrylic lenses. They correct cylindrical power, but they require accurate alignment and fixation of the lens. Because post-surgical, if there occurs rotation of the lens, then they can introduce additional cylindrical error. Accommodating lenses. So they change optical power of the eye with axial movement. 1 mm of anterior movement usually gives 1.80 diopters of accommodation. Crystal lens is the only FDA-approved intraocular lens for presbyopia. Now, special lenses are aniridia intraocular lenses, which have colored body and haptics. They are available for scleral and sulcus fixation. Telescopic intraocular lenses, which provide 25 times magnification of the central image and do not affect peripheral vision. They're used in macular degeneration. Piggyback lenses are used to correct post-operative refractive errors. Then there are scleral fixed or glued intraocular lenses, which are sutured, fixated, or glued to sclera through the sulcus, and they are used in absent or deficient capsular. Now, it is good communication and rapport with the patient, setting practical expectations and educating the patient is very important for choosing the correct IOL. A happy patient will lead to a happy life.
Yeah. Well
Very
done,
good.
Jayashree.
Well
But-
done. Good
Yeah.
job.
Yes. So in which cases would you explant an IOL? Have you heard of explantation?
In case of dislocated intraocular lenses.
Sorry, what was that?
Ma'am, in cases of trauma, when the intraocular lens gets dislocated, we will explant the IOL and put a secondary IOL.
Any other situation? Any other situation? Even without trauma? Yes? No? There are so many situations where you can need to explant, where you might need to explant. Purvasha madam is correct.
Anything related to the material
Yeah.
or the intraocular lens power calculation or not pertinent to trauma?
When the patient has residual refractive error.
No. Okay. It's okay.
It's okay.
Now, team 6. Priyanka, you are ready?
Yeah, she's already sharing.
Yeah.
Go ahead, Priyanka.
Start, Priyanka, please.
Priyanka, can you hear us?
Unmute yourself. Unmute. You are muted, beta.
Yes, ma'am.
Yeah, go ahead.
Yes, ma'am.
Start the timer.
Yes.
Yes, ma'am. Good afternoon, everyone.
Started.
I'm Dr. Priyanka Salonke. My topic of presentation is biometry. So, what is biometry? It is a physical measurement of ocular dimensions that are used as input variables for the various IOL formula calculations. So, accuracy of IOL power calculation depend upon the precision of preoperative biometric data, accuracy of IOL formula, and IOL quality control by the manufacturer. So, in this, we usually we are seeing the biometric data in this session. So, the axial length measurement is the most important factor in this calculation. The refractive 1 mm of error in the axial length measurement, resulting in the refractive error of approximately 2 diopter in the normal eye. Accuracy of axial length measurement is important in the shorter eye as compared to the long eye, as the refractive error rises to about 3 diopter in the short eye. So we have ultrasound biometry and the optic biometry. The ultrasound biometry uses a probe that emits a frequency of 10 megahertz, and it calculates the time taken by the sound wave to travel from cornea to retina to probe. Then in this we have the contact and immersion biometry. The contact biometry indent on the cornea, thereby resulting in the falsely shortening of the axial length. In immersion, we are using the coupling fluid separate from the cornea. These are the technique. So ultrasound biometry usually measures the anatomical axial length, measure till the internal limiting membrane. So we have to add additional thickness of retina, about 200 micron, and accuracy is around 0.1 millimeter. So The main advantage of the using ultrasound biometry is that it is useful in the dense mature cataract. In optical biometry, it usually measures the optical axial length. There's no indentation, so there's no error. Accuracy is around 0.012. It is more accurate in the myopic eye, staphyloma, and in children as silicon filled globe. In optical biometry, we have LensStar, IOL 500, and IOL Master 700. The only limitation about the optical biometry is that it cannot penetrate through the dense cataract. This is overcome by the swept source OCT technique. LensStar in LensStar, we are using the optical low coherence reflectometry principle. And in case of IOL Master 500, we are using the PCI principle. In IOL Master 700, we are using swept source OCT technique. The cornea power is the second most important factor in the calculation of formula. One diopter of error in the corneal power resulting in the one diopter of post-operative refractive error. It can be calculated by the keratometry or the corneal topography and the tomography technique. New addition to this are the video keratography techniques. So it based on the principle of anterior surface of cornea act as a convex mirror and the side varies the curvature. So using doubling principle, we have two keratometer. Bosch and Lomb keratometer, it uses the fixed doubling principle, and Javel and Schwartz, it uses the variable doubling principle. Keratometry measures the horizontal and vertical meridians of a range about 36 to 52 diopter. We can increase the range by placing the plus and minus lenses in front of the aperture. So only limitation is that it assumes the cornea as a thin symmetrical spherical structure and measure the central corneal thickness, and it does not consider the posterior corneal astigmatism into account. These limitations are overcome by the newer technique like automated keratometry, tomography. In addition to the anterior curvature, the tomography measures the posterior corneal curvature and the corneal pachymetry. What is the effective lens position? It is the effective distance between the anterior surface of cornea and the lens plane. If the lens was infinitely thin, it is determined by the IOL manufacturer as a constant. It is the main limiting factor for refractive predictability after cataract surgery.
Priyanka, your time is up.
Time is up.
Yeah.
I have to stop. Yes, Purusha?
So Priyanka, you've covered it exhaustively. Patient with hypermature cataract comes to you. What is
Yes,
your
ma'am.
choice of biometer?
Ma'am, in hypermature cataract, ma'am, immersion biometry.
And why so?
First, in optical biometry, it is not ma'am, either ultrasound biometry or swept source OCT will be sufficing.
If you have a child with congenital cataract, how will you do? Small child, say about
Ma'am, ma'am, swept source OCT.
Sorry?
Swept source OCT.
Okay, and if it is that facility is not available, then something simpler. No? Okay, fine. Let's go. Please stop sharing your screen.
Yes, ma'am.
Go to the next.
Next, Sadaf, please. Dr. Sadaf, start sharing, please. Okay, they are sitting as a team. Good.
Yeah, they're together.
Please share.
Yes, ma'am. Ma'am, am I audible?
Yes.
Waiting
Okay, ma'am.
visible.
Okay, ma'am. Good afternoon, everyone, and a very happy Independence Day to all. I'm Dr. Sadaf Nas, first year junior resident from Grants Medical College. My topic for today is treatment of neovascular glaucoma. To understand the treatment better, I would like to introduce a bit about neovascular glaucoma.
Sadaf?
Secondary to the neovascularization. Yes, ma'am. Yes, ma'am.
Please go ahead.
neovascular glaucoma develops secondary to neovascularization of iris, which is called as rubiosis iritis, leading to the progressive angle closure and lipid glaucomatous atrophy. In this picture, you can see this is rubiosis iritis with vascularization seen at the iris. The pathogenesis is, ma'am, the idea is there is ischemia of the retinal tissue due to various factors like diabetic retinopathy, CRPO, that causes the release of angiogenetic factors like VEGF. That is vascular endothelial derived growth factor that causes new vascularization of iris, thereby obstructing the outflow pathway, causing the glaucoma. Then coming to the treatment part, there are some treatment options available, but no treatment is ideal. We'll have to combine one with the other to have the desired effect. These are pan-retinal photocoagulation, pan-retinal cryotherapy, anti-VEGF agents, medical management, surgical management. Now, for pan-retinal photocoagulation, our idea is we have to reduce the oxygen demand of the retina so that there will be decrease in the neovascularization. In pan-retinal photocoagulation, we ablate the peripheral part of retina, so there will be decreased oxygen need, decreased stimulus for angiogenesis, and decreased neovascularization, thereby preventing neovascular glaucoma. PRP is basically it is useful in earlier cases, like in open angle glaucoma and earlier part of the angle closure glaucoma, provided that the synovial closure has not exceeded 270 degrees. However, if PRP is done before vitrectomy for diabetic retinopathy, it doesn't help to prevent the rubiosis iritis. This is a picture showing pan-retinal photocoagulation. You can see the periphery has been ablated with the laser spot seen. Next is pan-retinal cryotherapy. Idea is the same. We have to destroy the peripheral tissue, but here we use intense cold, about 50 to 60 degree temperature, with the use of gases like freon, nitrous oxide, carbon dioxide. This is the picture showing cryo probe and a cryo unit. Then anti-VEGF agents. These are the agents that are injected in the anterior chamber or in the vitreous cavity, which antagonizes the effect of VEGF, thereby reducing the neovascularization. The advantages are it is faster in action, safer, and its effect lasts for several weeks, and it is well tolerated by the patient. But at the same time, the advantages are that several injections will be needed, and patient compliance is an important factor, which will be PRP. We will have to combine it with some other procedures like PRP or surgical procedures, and it is associated with increase in the intraocular pressure like any other intravitreal injection. Then medical management, it doesn't help much. It helps only in the earlier stages. So we have two ways. Either we can decrease the aqueous production or increase the outflow. Increasing the outflow will not much help because the outflow pathway has been obstructed. So we use the first path, and we use ABC, that is alpha-2 agonist, beta blocker, and carbonic anhydrase inhibitor. Prostaglandin we don't use because it exacerbates the inflammation, and the pathway is all anyway obstructed, so it is not much useful. Coming to the surgical procedure, these are the procedures used when non-surgical processes fail or it does not give the desired effect. The main surgical procedures we have are cyclodestructive procedure, filtering surgery, and glaucoma drainage devices. In cyclodestructive procedure, we do transscleral Nd:YAG photocoagulation to destroy the ciliary epithelial tissue, thereby decreasing the aqueous production. Its clinical benefit is not, it is very variable. The response is very variable. Then filtering surgery, it also has a lesser success rate because of high risk of intraoperative bleeding and postoperative progression of fibrovascular membrane. The available options are trabeculectomy and modified trabeculectomy. To increase the viability of trabeculectomy, we should use micromassive.
Your time is over.
Okay.
Just in time. So, Sadaf, well covered. How would you distinguish between normal iris vessels and new vessels of the iris?
Okay, ma'am. Ma'am, the normal iris vessels, they will seem dilated, but they will be radially present. But the new vessels, they are present mostly around in the peripupillary region.
And the pattern will be?
Arboreous pattern.
That's right. Very good.
One question to you, Sada.
Yes, ma'am.
Vascular glaucoma is a part of secondary glaucoma. What are the other types of secondary glaucoma?
What are the other types of glaucoma?
Secondary glaucoma.
Secondary glaucoma. Okay.
Because there's primary glaucoma and secondary. Neovascular
Yes,
glaucoma
ma'am.
and the secondary, isn't it?
Yes, ma'am. Yes, ma'am. Ma'am, if Ma'am, if ma'am, secondary glaucoma can be due to the in earlier cases of cataract also, if there's phacomorphic glaucoma, it could be a cause of secondary angle closure glaucoma.
Okay.
Or if there is any mass in the any intraocular mass like retinoblastoma, it can also be causing secondary angle closure glaucoma.
Very good. Thank you.
Thank you, ma'am.
Dr. Amruta, can you go to your first slide? Make it full screen. Dr. Amruta, make it full screen. Come to the first slide.
No, you've gone back.
Out.
Start your screen share again. Start sharing your screen again.
Dr. Amruta. Dr. Namita, are you ready?
I think they're both together. And
Namita, can you hear me?
who's their mentor? Nana?
Dr. Miloni? Dr. Miloni?
Yes, ma'am. Yeah, I'm here. I'm here. I'll just figure out. I think their network is an issue.
Yeah, because I cannot see anything, only the names. I cannot see
Yeah,
anything.
I have messaged them. I think Amrita has started screen share.
No, not yet. She
Not
hasn't.
yet.
She started.
Yeah,
and
she just.
Can you talk to them, please?
Yes, I'll just have a.
Okay.
Yeah. Yes.
Yes.
Okay. Make it full screen.
Yes, Amruta, make it full screen, please. Are you able to listen? Are you able to hear us? Is the same get what?
Nana.
Yes, you are there.
Go ahead.
Please, can you start? Amruta, we are not able to hear you.
Amruta, unmute yourself.
Amrita, you need to unmute.
Yes, ma'am. Yes, ma'am.
Yes, better. But
Am
it is
I
stuttering.
audible, ma'am?
Yeah, but it is stuttering, beta.
Yes, ma'am. Hello.
It's better.
Hello.
Yes,
Am I audible, ma'am?
better. Yes, better.
Go ahead.
Yeah.
Hello.
We
Go
can
ahead.
hear you, Amruta. Please start.
Hello, Amrita. Start your presentation. Hello. Amrita, we cannot hear you.
He disappeared from the
He is not there actually.
He disappeared from the screen. Yes, Amruta. Yes.
Good
Amrita, I
afternoon,
think
everyone.
your
I'm
network.
Dr.
Yeah.
Amruta.
Yes.
Hello. Yes, ma'am. Hello.
Yes.
Hello. Good afternoon, everyone. This is Dr. Amruta.
I think your network is poor, Amrita. Your voice is breaking. The network doesn't seem to be okay.
Hello.
Yes, go ahead. आगे बढ़ो.
Hello.
Yes, we
Hello.
can hear you, Amrita. Go ahead.
Hello.
Madam, time lag is
We can
shared.
hear you.
Hello.
Please go ahead with your presentation, Dr. Amruta.
Hello. This is Dr. Amruta. My topic is fungal.
Let her go ahead. Let's not interrupt her.
Hello. This is Dr. Amruta. My topic is fungal corneal infection.
Yes, start the timer.
My topic is fungal corneal infection under guidance of Dr. Miloni Sharma. What we are going to fungal corneal ulcer. So fungal corneal ulcer is a big issue as it affects the young individual, which is their working period, agricultural worker. Morbidity is higher as there are very poor visual outcomes, no effective antifungals as of now,
Dr.
and less
Sujit,
availability of
unmute yourself, please.
donor cornea. So fungi are classified basically on upon yeast, filaments, and diphasic. Yeast are more commonly found in Western countries. Among filamentous, fusarium is more common in South and East India, and aspergillus in North and West India. Then diphasic fungi are rare.
Then risk factors include corneal trauma with the vegetative matter and pre-existing corneal pathologies, chronic corticosteroid use, or systemic diseases. Idiopathogenesis, there is need of breach in the first and foremost thing required to fungus get infested is the breach in the continuity of the epithelium, which causes the adherence of the fungi to the cornea, which leads to invasion and growth. The hyphae grows along the stroma of the cornea and leads to damage by release of mycotoxin and host immune response, which leads to following clinical features. We know there is an indolent course where the signs are more than the symptoms. Patient comes with pain, redness, blurring vision, watering, and in signs we can see the pseudodendrites, feathery margins, then satellite lesions, raised margins with a endothelial plaque and hypopyon, and pigmented corneal ulcer. Coming to diagnosis, laboratory confirmation is must. For that, we do the vigorous scraping from the edges with the help of Kimura spatula and send for staining, which mainly includes the KOH mount, culture, and if our report comes on negative on culture and strong suspicion is there, then we go for PCR and confocal microscopy. These are Montgomery methamin silver stain, calcofluor, and this is confocal microscopy. These are the fungal. Coming to treatment, first is amongst this, the main is natamycin, which acts by alteration of cell permeability. Then MUT1 and MUT2. MUT1 says that the topical natamycin is far better than the voriconazole, and MUT2 says that there is no comparison found benefit to the oral antifungal over the topical. Other modalities of treatment are intrastromal injection and intracameral, which includes voriconazole and amphotericin B. Oral are when there is more than 2/3 of the corneal stroma and more than 5 mm size scleritis and endophthalmitis. TSC protocol include topical systemic and targeted. The first in that first is topical natamycin, second is topical voriconazole, so third line is intrastromal antifungal, and then therapeutic keratoplasty. In the therapeutic keratoplasty, perforation, impending perforation are the main. Then newer in the corneal ulcer is collagen cross-linking. This is summary where the take-home message is geographical variation exists in the fungal corneal ulcer. Cocktail therapy should be avoided. There is need to differentiate from the pythium, which leads to dreaded complications. And coming to this, if less than 2/3 of cornea stroma is involved, less than 5 natamycin 5% should be started too early. Then response is better. We continue, and if more than 2/3, then topical voriconazole and targeted therapy, and further we go for TPK. Thank you very much. Happy Independence Day to all. Hello.
Yes, done.
Stop sharing. Stop your screen.
Yes, ma'am.
Yeah, Namita can start sharing meanwhile.
Rupali, want to ask something? Rupali?
So in all of these, what is the most important thing in fungal ulcers in terms of
Feathery
management?
margins. Okay. In terms of management, we should be sending the first scrape. First, we should focus on the morphology. If signs are suggestive of corneal fungal infection, then we should scrape the edges and send for the smear. In that, 10% KOH mount is must. And then starting topical natamycin, 15 minutes for daytime, means for 1 hourly, then tapering as per the response comes.
Correct. So it's important that the KOH mount be done, because any other, unlike in the bacterial where you'll get your culture reports back quickly, you're going to have to go basically on your clinical judgment and your KOH mount.
Yes, ma'am.
Right. And also, Dr. Amruta, I would just try to make one comment. You have mentioned vigorous scraping. So I don't.
Okay.
Vigorous scraping is never to be done for a corneal ulcer. It is to be very. For scraping, when you do diagnostic, you have to be very gentle. It's never vigorous.
Yes.
Okay.
Okay. Namita,
Namita. Yeah. Yes. Start from slide 1. Yes. We can't hear you though. Make it full screen. Yes.
Yes, good.
Yes.
Can't hear you, but
Yes, Namita, start. Should I start the? We are not able to hear you. Hello, can you hear us? You're not audible, Namita.
go back.
Your screen was perfect.
Only your voice could not be heard.
Yes.
Go back to full screen.
From the beginning.
Why can't we hear her voice?
Yeah.
Namita? Hello, Namita? Can you hear us? Miloni, can you just call her and talk to her?
I think same problem for all. Aryamol also.
Yeah, I'll just call her up.
I think
this,
Naina, because Amrita also had a network issue. Her voice was breaking in between.
Yeah.
I think they are sitting in the same place, possibly. Let's see.
They have separate IDs, ma'am. They have logged in separately from.
Okay. But Namita, don't go back. Remain on full screen.
See, I will try.
I think one thing we should have done was maybe got all their presentations with Numerotech and asked him to.
Standby, you can keep them,
But at least we should have kept.
Yeah.
It's a lesson learned for us for the next round. Namita, can you hear us? She's not answering at all.
Hello. Hello.
Miloni, could you contact her, please? Is Miloni there?
Ma'am, Malik ma'am, I called her. She said she can hear us. She's trying to, but her voice is not getting through. But we are all audible. Everything is audible to her. And she's trying. She's struggling, she said.
She's traveling.
Struggling. She's trying.
Oh, struggling. Oh, God.
Don't know why. Again, this is not the Apple format में थोड़ा I think initially problem आ रहा है सबको ही. This happened with Aryamol, Ganesh also.
She is able to listen, but
Yeah, that's what she told. I called her up now.
Namita, in that also there is I think where you can your headphone I think is not audible or something, or if you're using a loudspeaker, there is an option in the settings.
Yeah, you
Try
change the
that.
mode. Change the mode.
She can just do away with the, headphones and just speak. The laptop volume is good enough, really. You don't really need to use it.
See that she's unmuted, madam.
But we can't hear her.
We can't hear a single word.
No, and
The last speaker.
Yeah, she's the last speaker. We have to finish with her. Namita, can you send your? No, but she has to talk. Do you have any other laptop around to which you can shift? No. You don't go on that. Don't go on that at all. What you want is volume. Because again and again you're going back to slideshow, not full screen.
Your full screen. Can you try shifting the slides? See that whether you're stuck here only.
Try going to the next slide.
Next slide.
Know how to go to the next slide? What came up? In that there was next right on top, or at the bottom left. If you go, as Purvasha had guided the other
Madam, can I do one thing? Can I call her and she can talk on phone and I will keep on speaker? Is that okay?
Naina ma'am, I think Amrita has reached her room. I told her to go, and I think they are figuring.
Or
I
the
think
other option is, yeah, I can make a WhatsApp call to her and keep it on speaker.
Whatever, Nana, we are okay with anything. We just want to hear them.
Correct,
Yes.
correct.
The whole purpose is that we need to see how their presentation is, how they talk.
Yeah, and there's a big network issue at TNMC.
Is it?
Yeah, ma'am. It's bad. Even our घर से कभी phone आता है तो they get bugged up.
नहीं, but then
Not contacted. That's a big problem. I don't know why.
but if they knew this was the issue, they should be in some other place.
And they should have used the cable network.
Whatever, huh? See, because this is an important thing, no?
Correct. I will do one thing, ma'am. I'll call her up and ask her to speak on her phone. If that's okay with the judges.
Her presentation is going ahead because she just now changed it.
Yes.
Ma'am, what I've done is Amrita has gone to her room, so Amrita's speaker will be on and Amrita will present from the screen.
Sure.
That's fine. That's
Good.
fine.
Ask her to go ahead.
Yeah. Amrita, you can unmute. Amrita, if you're there, hello. Both of them are logged off.
But Miloni, how will Namita be on her speaker?
No, Amrita and Namita are together now. So I just told Amrita to unmute and Namita to share the screen.
She's already sharing the screen.
Yeah, so I think there is some issue with the headphones or some microphone problem. I'll just 1 minute. Amrita?
Milan, best would be to let them speak on phone.
And continue.
On electronic network and everybody can hear.
Okay, I'll do that.
Yeah. Shall I call her? I'll call her.
All right.
Is this the last presentation of this session?
The last presentation, Santosh.
Because I think Central 2, Central 3, Central 4, they have all finished.
They've all finished? Okay.
And they have already joined. So
केलंय मॅम माझ्या याच्यावरनं ऑडिओ राहील
Yes.
तुझं शेअर झालेलं आहे
ओके मॅम बोलू का
तू स्टार्ट कर माझ्या फोनवर
ओके मॅम माझ्या याच्यावरून बोलतेय
ऑडिओ सुरू
आणि माझ्यावरून प्रेझेंट करते
Go ahead.
ओके मॅम गुड आफ्टरनून
Sir, audible, yes. Timer to start now.
हॅलो येस मॅम करू प्रेझेंट मॅम
Yes, please.
हा सॉरी फॉर द डिले good afternoon everyone. Happy Independence Day. I'm Dr. Namita Bhore, presenting under guidance of Dr. Miloni Shah ma'am. So what are we going to learn today is ARMD, pathogenesis of ARMD and commonly used anti-VEGF, biosimilars of anti-VEGF and adverse effects of them. So it is an acquired degeneration causing central visual impairment. There are two types, non-neovascular, which has drusen and retinal pigment epithelial abnormalities, and neovascular has above ones and the choroidal neovascular membrane formation. Advanced has subretinal hemorrhage or serous fluid added with it, or subretinal fibrosis. Change of नहीं है.
Hold the timer.
Namita, you've gone on the previous slide.
Yes. Hello. So pathogenesis for dry ARMD is through activation of RP cells, deposition in RP. There is lipofuscin deposition called drusens in between the Brooks and RP membrane. In wet ARMD, there is a secretion of proangiogenic
pathogenic factors causing increased VGF, and there is choroidal thickening. The clinical features most commonly are metamorphosia, decreased vision, contrast sensitivity, and we can use of Amsler grid chart, which can be used for the same. Progression from dry to wet ARMD. Then there is VEGF-A, which are causing it. VEGF-A to E. VEGF-A induces angiogenesis through the new capillary formation, migration, endothelial proliferation. Phase 3 trials of randomized control trials have shown, you learn it with the short form EBR. A is for proteins, which has ligand binding elements, FC portion. It has better affinity than ranibizumab and penetrates through all three layers, all the layers of retina. Second is ABC bar. It is in the preclinical studies. It has greater durability than that of ranibizumab. Bevacizumab was first commonly off-label used. Now it has, from 2016, it has been used with FDA approval. It inhibits all isoforms and causes proteolytic breakdown of VEGF-A. And brolucizumab is a newer drug which binds to the FC portion of IgG and complement determining regions. It has, however, side effects like redness of eye and hello. So it has been not been used as much. Ranibizumab is most commonly used in our setting, and it has recommended Fab fragment that has been affinity mature to increase its VEGF-A. It is binds to all the biological active forms of VEGF-A. The two main trials which we should remember is Marina and Anchor trials. So again, biosimilar and biologic are two types. Biosimilar are the recent ones. They are for ranibizumab we use razumab, which is better, more biologically active and FDA approved and better cost. Then the current strategies which are used are PRN, which includes fixed interval dosing or monthly visits called Prorinata. Then there is TREX, treat and extend trials, which is progressive extension of treatment and visit interval up to 12 weeks depending on the clinical findings. Then there is side effects which we see are subconjunctival hemorrhage, vitreous floaters from medications of vitreous hemorrhage, and ocular irritation or pain because of the corneal epithelial disruption or abrasion caused by the antiseptic used to prepare the ocular surface before the injection. So thank you and happy Independence Day.
Okay, thank you.
Lots of struggle. Ultimately, it went through.
Yeah, but her voice was breaking throughout.
No, this is
what problem was
everybody should remember next time.
Okay.
You can stop the screen share.
Stop sharing your screen. End show. Go to end show. Yes. Purvesha, want to ask something?
Yes. So, Dr. Namita, what would be, as a postgraduate, how would you get your patient ready for anti-VEGF injection? How would you, what would be the preoperative workup?
First, I would like to do clinical examination, contrast sensitivity, and I will see the vision, and I will do OCT to find the fluid accumulation, and I will have fundus photographs to explain the patient for the pathologies they are having. I have to show them the progression. I'll give them Amsler grid chart to show their progression from the disease. And if I'll show if it is, I'll give them like if there is sudden decrease or anything, I'll tell them to come and give them options. First, if it is intermediate ARMD, I would like to prescribe vitamin A, C, and beta carotene drugs, and wait, and ask them. I would see the progression. And if there is lot of fluid accumulation seen on OCT, I would give them options of various anti-VEGF drugs. Depending upon the affordability, they could choose.
So once you've decided that you're going to give an injection, what are the investigations that you would go ahead with?
Considering anti-VEGF, I would like to start with tandem blood sugar, fasting and postprandial and HbA1c level. They should be maintained. And before giving any intravitreal injections, it is very important for sugars to be in control, giving the risk of endophthalmitis. That's all.
Okay.
Can I ask one question?
Yeah, sure.
So what would be your anti-VEGF of choice if the patient has a history in the past of having had a stroke? Here, cost is not just the only deciding factor, and also if the patient is having what has clinical features suggestive of a PPCV, then what would be your anti-VEGF of choice? So it's not just the affordability of the patient, but also the underlying disease pathology in the broad area of neovascular membranes, which will decide which agent to give.
We would wait to give anti-VEGF.
No, I don't think you got her question, Amrita.
So you have to give if you wait, a patient has got a huge membrane, he's going to scar, and then giving the anti-VEGF is not going to be useful. So patient has had a stroke 1 year back. So some anti-VEGFs are to be avoided. It's not that they will cause some problem, but they are to be avoided. Which will you avoid? Is what I'm asking.
You know the answer, Amrita?
No, ma'am.
Okay.
Okay, fine. Fair enough.
One question. In which setting will you give anti-VEGFs? I mean,
OT versus OPD.
No, we will give in OT in all aseptic precautions. We're taking all the aseptic precautions.
Correct. Okay. Thank you so much.
Yes, we are done with all the teams. We had 7 teams in all.
Naina, the students can leave now so that we can.
Yes, you can exit. All the participants and the mentors can exit, except the 3 judges, the managing committee members, and the coordinators.
Yes.
Thank you so much. It was a wonderful session.
Yes, absolutely.
Holiday well spent.
And everybody spoke very well. Kudos to all of you.
They all tried their best.
They tried their best.
Variety of presentations, and it was nice activity.